Good evening. And we are going to be discussing the surgical treatment of atrial fibrillation. I have with me here two experts, Dr. Suresh Joshi, who is the Director of Cardiac Surgery at Jaslok Hospital, Bridge Candy Hospital and Leelavati Hospital, and also the Director of Wokhad Pediatric Cardiac Center in Bombay Central, and Dr. Anil Jain, who is the Chief Cardiac Surgeon at Sal Hospital from Ahmedabad. And I am Dr. Ganesh Iyer, the Chief Cardiac Surgeon at Aster Hospital from Bangalore. And I will take the lead in moderating this session and ask the relevant questions. We know that atrial fibrillation is a significant burden, medical and economic, on the society, and it carries a significant cost to manage these patients. Some of them have only atrial fibrillation, which is called lone atrial fibrillation, and some of them have associated disease for which they come for surgery. That's when we do the surgical ablation, and it is called as concomitant ablation of surgical AF. Now, coming to the first question, Dr. Joshi, when do you think we should consider surgical ablation in patients?
Atrial fibrillation, as you know, is a very serious public health problem, I would say. Won't be wrong if I say that, because unfortunately we do not have a statistic epidemiological study in India, but if you project the incidence that is in America and Europe, it's really mind-boggling, especially since the life expectancy is increasing. So an approximate 4 to 5 million patients in America have atrial fibrillation, and close to 35 million people in the world have atrial fibrillation. Now, why is atrial fibrillation so important? Because obviously it has very serious consequences. It causes embolization, stroke, all that we are very well aware of. It reduces the longevity, and also it's responsible for bringing down the quality of life, which is so much being talked about these days, especially since the more and more older people are there in the world all over. So atrial fibrillation really requires a very aggressive management. Unfortunately, medication and the drug therapy have fairly limited application because the results are not as satisfactory. In fact, the treatment for atrial fibrillation was initiated by Dr. James Cox way back in 1985. As a surgeon, he tried to treat the atrial fibrillation by surgical method called Cox-Maze procedure, and which has fairly good results over the years it has developed. But since it's being surgery, naturally we would like to avoid it as much as possible and try and see if the medication can help, and if not, if there is any other way we can manage it, and that was the catheter ablation came in, and which has been very aggressively pursued in last 2-3 decades. Unfortunately, it does not have as good result, and that's when the surgeon's role has come in more and more. Although it's a surgery, the results of surgical maze is so very good, and it's really a treatment of choice today for atrial fibrillation, especially if they are not responding to medication, and especially they are of long duration. The paroxysmal or the short duration one may respond to medication, but majority of the cases with atrial fibrillation, I would like to say, are surgical cases.
I'd just like to take this one step further, because a lot of our cardiology colleagues always keep quoting the Framingham study, which came to the conclusion that the rate control versus rhythm control has got no advantage. Would you like to throw some light on that in terms of, do you agree with that conclusion? I know we discussed earlier that it's a flawed study to begin with, but if you can throw some light on that.
I wouldn't say it's a flawed study, but there are some limitations to Framingham study which are quite debatable. But even then, rate control and the as you say, rhythm control is extremely important. Again, it all boils down to quality of life. Some patients are pretty asymptomatic and probably may not feel anything, although they have, as we call, asymptomatic or silent AF. So, and some people are very much disturbed by palpitations, and they are the patients who come forward for treatment. So we are a little more aggressive, especially the cardiologists are more aggressive for managing patients who are symptomatic. But all the same, if you look at the long-term results, either symptomatic or asymptomatic, the complication rate is very, very similar to both the conditions.
Thank you. Next question I would like to direct to Dr. Jain. In your practice, when would you like to consider ablation surgically?
Well, as surgeons, we frequently get patients who have a need for surgery, may it be coronary bypass, may it be valve replacement, maybe it valve repair. So when a patient is heading for some form of surgical intervention, either it's a bypass surgery or a valve repair or a valve replacement, then that gives us a golden opportunity, if they have a coexistent AF, to correct it. So if surgery is being done for lone AF, that's not a very popular or very palatable thing right now, because somebody has got atrial fibrillation and we are going in just to do pure surgery for atrial fibrillation. But if a patient has coronary artery disease and he needs a bypass, if the person is having a mitral valve disease and we are going in to do a mitral valve replacement or a double valve replacement or any other cardiac intervention, when you are opening the chest, that gives you a golden opportunity to correct the atrial fibrillation. Now why is it so? Because surgery is major. You have to go on pump, you have to open up the chambers, at least if you want to do a monopolar maze using monopolar cauteries, then you have to open the left atrium, the right atrium, and if you want to do a bipolar thing, you also have to put clamps on the pulmonary arteries. So if you want to do such an extensive procedure, then you have to open the chest and go in. There are ways of doing it minimally invasive, but so I think the best opportunity is to correct the atrial fibrillation when you go in to do an associated surgical procedure. So I would say concomitant maze is the way to go. Now the other thing is, if you just go in and you do a mitral valve replacement with a tissue valve for a patient with atrial fibrillation, you would still need anticoagulation postoperatively. If you do a mitral valve repair and you get the patient out in atrial fibrillation, that patient would need anticoagulation. Or you do a coronary bypass surgery and come out, the patient is going to continue to need anticoagulation, and all these things add up to long-term mortality and morbidity. So as they say, if you want to neutralize the disease, like neutralize atrial fibrillation, then the only way of doing it is by performing a surgical maze operation at the time of surgery. So in my practice, lone AF is very rare, for which I go in and do a atrial fibrillation surgical correction. Most of the patients are one who headed for some of the other surgery, having concomitant maze procedure.
I have a question that I would like to address to both of you. Is that there are patients who we see in clinical practice who have had paroxysmal AF.
Yes.
But when you take them up for surgery, they are in sinus rhythm.
Yes.
Should we address those as well?
Yes.
Okay.
I think
just
any
to clarify
patient,
to the people
even
who are
if
seeing,
there is one cardiogram which shows a paroxysmal AF, then I think that person should get a maze procedure.
Good. I agree with that, but I just wanted
Yes,
to clarify.
that should happen.
If I may go one step further, especially if you are operating on a mitral valve, where often you see an enlarged left atrium, which is a main cause of atrial fibrillation, because the initiation of atrial fibrillation predominantly happens around the pulmonary veins. So even if he has a paroxysmal, certainly we will do a maze procedure. But not only that, even every case that I operate, every case that I open a sternum, I always ligate or remove the atrial appendage. That's a standard procedure. That's mainly because if you see the statistic, we have close to 25% of the people in the world are going to develop atrial fibrillation after the age of 40 or 50. Every fourth person is going to develop before he dies an atrial fibrillation. And as you know, the embolism is so highly associated with atrial fibrillation.
And we also know that the quality of life that you mentioned earlier,
right.
Reduced life expectancy, stroke and other things are all reduced.
That's right, because the stroke associated with atrial fibrillation is far more severe than the normal stroke. Correct. It's been proven that the atrial fibrillation causing stroke is far more graver, and it's the person with an atrial fibrillation has 5 times more chance of developing a stroke than a normal population. So every time I go in, I just chop up the atrial appendage.
Excellent.
It's a grave disease. It has to be treated. Atrial fibrillation, you have to try and cure it where possible.
Agreed. We are all surgeons.
And the only way is when you go in.
So taking this further, now agreed that we have to do something to the patient to correct the atrial fibrillation. I'm sure the viewers as well as us know there are many methods in which atrial fibrillation can be corrected surgically. Let's walk through it step by step, or look at what are the various options that the surgeon has to correct the atrial fibrillation, and then we can discuss a little bit about the efficacy of each of those. Dr. Joshi, would you like to start by?
Yeah, well, classically the James Cock operation, he started by doing what is called as cut and sew maze procedure, where after doing a lot of canine studies, he found out that the pathways that he can cut through, so that he can create the lines of obstruction for the re-entrant impulses, so that the atrial fibrillation does not propagate.
Yeah,
so one of the best method was to cut and sew, so that the fibrous line passes, the waves are not transferred.
It's a scar, transmural scar is formed.
So that was the basis of the maze operation. So over the period you realize, because this is a very complex operation requiring long time and also some amount of surgical dexterity. So over the period, with advance in technology, the radio frequency ablation has come in. Before that, the cryo, the freezing of the tissue. The freezing of the tissue results into the crystal formation in the cell, and it destroys the cell, and then eventually over several days it forms a fibrous band. So that came in the cryo ablation. Now the radio frequency ablation has come in. And also there are other energies which are being used, like microwave, and even the ultrasonic energies are being used, but obviously they are not.
That's called HIFU, I think. High frequency, high intensity focused ultrasound.
Ultrasound is being used in some of the MRIs these days. They use high frequency,
focused
MRI
ultrasound
ablations. But that somehow has not come into practice as much. It's remained still in the experimental lab. Some laser technology has come in, but it's not still very popular. The most popular one is still the radio frequency ablation.
Now, coming to these energy sources, as you mentioned, cryo has got its limitations in terms of it can be applied only in one direction, either endocardial to epicardial or epicardial to endocardial. The laser also is quite similar. The high intensity focused ultrasound is also pretty similar. You cannot do both ways. So in terms of achieving transmurality of the lesion, which seems to be quite critical in the success or the final outcomes of the maze procedure, we are today limited with probably radio frequency ablation. Would you agree with my statement there? Or,
yeah, of course. The best is of course surgical.
Yes.
The best
next to surgery. Yes.
Next to surgery will be radio frequency ablation, but bipolar. The reason being that with the unipolar, the transmurality is not achieved in 100% of cases. Sometimes it's as low as 30 and 40%. So that's not really acceptable. Now that essentially variable, because the thickness of the left atrial and the right atrial wall is variable, and how much energy to apply and at what thickness is there is no confirmation, and that's why the bipolar is far more superior. But even better is actually cryo.
Cryo is the best.
Cryo is supposed to be next best to the surgical.
Okay.
In terms of transmural, complete transmural achievement of the line formation.
Okay.
And it's also safer because it can go fairly close to the coronary arteries as against the radio frequency. If it is unipolar particularly, it can be a bit dangerous to the coming closer to the coronary, especially in the AV groove and the coronary sinus.
Perforation.
Excellent. We'll move ahead. Another imponderable or variable in the outcomes of the maze procedures that are reported, we see other lesion sets. Some people do only a left atrial isolation, some people do only a pulmonary vein isolation, only a left atrial maze, or some people advocate a biatrial maze. What do you think? What are your thoughts on that, and what should one be doing?
Well, see, the principle of maze is about preventing the macro reentrant circuits. So the more lines you create, or the more obstructions you create for this macro reentrant pathways, the better is the outcome. So these pathways exist around the pulmonary veins, around the mitral valve, around the left atrial appendage, around the right atrial appendage, near the tricuspid valve, near SVC, near IVC. So the more interruption that is made to the macro reentrant pathways, the better is the chance that the patient will stay in sinus rhythm. later on. Because like Dr. Joshi said, it's about transmurality. You are not sure how many of the lesion sets you do will be transmural. If you're doing a bipolar, it's okay, 100% transmural. But when you're doing monopolar, you're not sure you've always got transmurality or not. So more the sets, it's better. One, left atrium always has to be done. Whatever happens, the most common place where these tachycardias come is around the pulmonary veins. So all the pathways around the pulmonary veins definitely have to be isolated. So pulmonary vein isolation is definitely a must, left atrial appendage is a must, and lines drawn from mitral valve to the pulmonary vein isolation lines is a must. So the left definitely has to be done. There is no maze procedure where you do not do maze for left atrium. Second is adding the right atrium, especially if the patient has got tricuspid regurgitation, the right atrium is dilated, it is very thick and it's a long standing AF, then paroxysmal you can still do only the left atrium. But if it's a long standing atrial fibrillation, then definitely biatrial is very important. So adding the sets of radiofrequency maze in the right atrium definitely helps to improve the long term patient's chance of staying in sinus rhythm. On top of that, you can also go ahead and do bipolar on both the pulmonary veins. So that would definitely guarantee a sinus rhythm. So more the sets of maze lines drawn, the better is the chance of staying in sinus rhythm.
Yeah, I would just like to add one more point here, that the initial studies that Cox had done, where he found the majority of the reentrant circuits were originating around the pulmonary veins, were in patients with low atrial fibrillation. And the patients that we are treating are not patients with low AF, they are with structural heart disease. So we cannot be 100% sure that just doing a left atrial isolation will be enough. There is more to the pathology than the etiology of the AF in itself.
It's the hypertrophy of the left atrium, the dilatation of the LA and the RA that also are very important. The patients who have a bigger LA, a bigger RA have a less chance of coming back into sinus rhythm. So definitely if the left atrium and the right atrium are dilated, one would like to do more sets of lesions also.
Dr. Joshi, your views on when we do the bipolar lesion, especially the one that we use, is one burn enough, or because that says the transmurality is achieved as measured by the machine, or do you think that we should do 2 lesions at the same place to ensure greater transmurality?
Well, there is no harm in doing 2 lesions, but all you require, see by the bipolar, the heat that is generated is barely 60 degrees or 70 degrees, and the time that is required is barely 6 to 10 seconds. So if you feel that this particular atrium is rather thick, then there is no harm in putting 2 lesions. In fact, it will be an advantage. But we will have to be a little careful, especially on the venous side, because there is a small number, but a certain number of
where we can rupture the tissue.
More than rupture, there is a pulmonary vein stenosis. If you have a bit too close to the pulmonary vein, there is a very small percent of patient can develop pulmonary vein stenosis because of excess fibrosis. So if you want to do multiple lines, they should be a bit away from the pulmonary veins. And if it's a bipolar, it's hardly 10 seconds. You take one more 10 seconds as against the unipolar or surgical maze.
It takes longer.
In fact, when you asked about doing only the left-sided maze, the basic concept has come from that, because earlier it used to be a surgical maze.
Correct.
And with the peroxisomal AF, it's a very simple lesion. Even in fact, the success rate with transcatheter ablation is also close to 70%. But the chronic, long-standing atrial fibrillation, the transcatheter success rate is barely 30%. One of the reasons why it's not very successful. So that was a mindset that peroxisomal, you could do away with the left side. And also when Mays started doing his procedure, the Cox Mays 1 procedure, it had a fairly high incidence of heart block. Because there was a damage to the SA node, and that was more on the right side, and that there's multiple things that resulted in the mindset thinking that only left side is the maze. Actually not. The maze operation is always biatrial. It has to be biatrial.
Okay, let's move ahead. I'll talk about the bipolar sets. When you do on the pulmonary veins, they recommend, what's recommended is change the position of the clamps a little bit.
2 millimeters this side, that side.
Obliquely in different directions, so you can prevent, like they say, pulmonary vein stenosis also.
Yeah, moving ahead, just more recently, minimally invasive is a very big catchword in the surgical arena. Everybody seems to talk about it and wants to jump on the bandwagon. Your thoughts, Dr. Joshi, on the possibility and the efficacy of minimally invasive maze procedures?
I think it's a wonderful progress in surgery. The minimally invasive technique has not only become a standard of procedure for several intracardiac repairs and bypass surgeries, but also cases like atrial fibrillation treatment, because one of the reasons why surgery was not considered for atrial fibrillation was the magnitude of the surgery, sternotomy. Although the results were more than 90% success rate, still for a lone atrial fibrillation, people wouldn't consider going in for a surgery. But with minimally invasive approach, you have a small 3-inch, 2-inch mini sternotomy, mini thoracotomy, sorry, on the right side or on the left side, and use a bipolar radiofrequency ablator. Patient is the very low complication rate, and the patient can be discharged within 4 or 5 days and can be back to activity. So minimally invasive is really a very, very major step forward for treating atrial fibrillation.
But do you think we can actually do a biatrial maze that we said was so important?
Absolutely.
Through a minimally invasive approach?
Absolutely. Now there are two ways of doing minimally invasive ablation. Either you can do it on beating heart without a pump, which is only epicardial, as you call it, only epicardial ablation. So you don't do endocardial, which has somewhat inferior results compared to endocardial, open the left atrium, go on the left side and things like that. So if you put the patient on pump, and there have been several multi-center trials and review articles, and they have compared it that the morbidity related to minimally invasive on pump maze is absolutely as much as the
open heart surgery.
So it's very, very quick recovery, and one should really seriously consider, especially my cardiologist colleague must think of considering a minimally invasive surgical approach for lone atrial fibrillation. Yeah.
That's interesting. I think we are almost running out of time, but we'll wrap it up pretty soon. But before I conclude, I just wanted to get your thoughts, Dr. Jain, on it's certain that even in the US, the percentage of people who come to the operating room with AF, not everybody is getting treated. So obviously there are some limitations to the procedure, not in terms of efficacy, but in terms of surgical skill that is required or possible complications. So could you throw some light on the possible complications?
Yeah. One of using any of these energies like radio frequency, especially cut and sew, of course, is a big procedure, and that's associated with bleeding. It requires extreme degree of surgical talent or skill to be able to do a cut and sew, and it's about cutting everything and putting everything back together. That's one. If you're using one of these energies like radio frequency, then many a times if the proper irrigation is not done at the same time, or if too much energy is used, then there are chances of perforation. And sometimes after these procedures, especially if you do a very extensive job like biatrial and bipolar, then these patients can also end up into a complete heart block. More than that, sometimes if you've done a bipolar along the pulmonary veins, then you can also have some sort of a pulmonary vein stenosis also later on. So these are the few things. The other occasional complication known is, especially when you are doing the left atrial burn lines, you can have esophageal injury because of the heat transmitted from the exactly.
And the other thing is nowadays we have these TE probes which are there, which kind of push the esophageal wall towards the LA as well.
That's the other complication that can happen. Of course, for that you have to put a small sponge behind the
on the
left
contrary,
atrium.
actually the incidence of esophageal perforation is much higher with catheter ablation compared to the surgical.
Yes.
Yes.
So that's one more thing that can happen. So these are a few known complications that are associated with the maze procedure, and it requires extra pump time, extra surgery, and it adds to the cost also. Hence, it's like suppose you're doing a mitral valve replacement, you're just going to open the left atrium, do a procedure and come out. But if you're doing a biatrial maze, you have to open the LA, the RA, you do the burn lines, and hence sometimes people hesitate to go ahead and do all that extensive procedure.
Excellent. I think we have had a nice discussion so far. Only certain aspects we have not covered deliberately is the cost implications in the Indian scenario.
Yes.
But just to wrap it up for everybody, panel
Can I add a comment before we wrap?
Sure.
See, we talked about radio frequency, we talked about cut and sew, and we've talked about cryo ablation also. there's something that a surgeon can do routinely if he goes in for a patient with mitral valve replacement or double valve replacement. You can do a simple cautery. We have electrosurgical diathermy in the theatres, and many people have tried using this to create these burn lines, and that also gives a result. So, instead of doing nothing, doing ablation using even normal electrocautery can give us some benefit compared to not doing.
Excellent. So, to wrap it up, again I will just say that atrial fibrillation is a common event that happens during surgeons encounter in their patients. The panel here at least certainly feels that every patient should have ablation irrespective of the methodology used. We also feel that biatrial maze is probably the best long-term results and sustained results that are obtained. Bipolar radio frequency and in combination with unipolar probably works best in the Indian case scenario, if I can say so. And the outcomes are generally very good with rare complications. So I think with that I will conclude this session. Thank you very much, Dr. Joshi and Dr. Jain for being with us.
Thank you so much.
Thank you so much.
Thank you.